Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. I'm very delighted to share with you our session today, Ain Shams University Pediatric Surgery Department, as the second meeting. Actually, this meeting is a regular meeting in our department, and due to the coronavirus era, we try to keep our tradition, to keep up to date and with our patients and with surgical activities in general. Today we have 3 sessions. We try to make them having the same theme, one theme, which is traumatic cases. I think that we had the chance to deal with 2 interesting rare cases. One is hepatic trauma with complications in the form of biliary fistula, and the other one was a duodenal injury. And we try as well to add some scientific shape to our meeting, because we think that we need for building a culture of scientific thinking and scientific research, as well as we need to increase our capacity for dealing with the scientific and clinical research. So we will give a short resume about 2 important ways of dealing with the surgical evidence in the recent years, which are the systematic reviews and the meta-analysis. May I call Dr. Muhammad Sharif, our senior resident, to start share his screen to present the first case. The moderators for the first case is Dr. Muhammad Abdul Latif, Assistant Professor of Pediatric Surgery, Helwan University, and he is our dear friend and colleague, as well as Assistant Professor Dr. Muhammad Hisham. He is Assistant Professor of Pediatric Surgery at Shams University. Would you mind to start, Sharif?
A case of polytrauma. Ali Mustafa Farag, 3 years old and 2 months old, 13 kilogram, a case of road traffic accident with blunt hepatic trauma. Patient presented on 1st of February 2020. He was referred from outside hospital as a case of polytrauma, road traffic accident. He was in that hospital for 3 days, explored there due to hemodynamic instability. Liver lacerations were found, packs were applied to control bleeding, 2 intraperitoneal drains were left. On admission, the patient was admitted at our pediatric surgical ICU. General conditions: the patient was ventilated, jogged, pulse was 150, blood pressure 100/60, urine output was about 0.5 milliliter per hour per kg. The patient was resuscitated in the form of central IV access and resuscitation and IV fluids, fresh frozen plasma, and packed RBCs. 2 drains were inserted with serosanguinous output. Upon admission, bedside pelvic abdominal ultrasound was done, showing in the liver diffuse abnormal hypoechoic coarse parenchyma with echogenic portal tract with the right loop echogenic area suggesting hypoperfusion, suprarenal hemorrhage and right perinephric rim 5 milliliter collection, and perihepatic and perisplenic collection. Challenges: liver laceration and late biliary fistula, elevated kidney functions, neurological deficits, prolonged immobility and ventilation. First, liver laceration and late biliary fistula. Exploration was done 36 hours after admission. Packs were removed. Peritoneal toileting was done, and hemostasis was ensured. 2 drains were left, subhepatic and pelvic. 1 week post-operative drains were removed as the output was nil. A week later, patient started to develop progressive abdominal distension. Pelvic abdominal CT was done, showing extensive right hepatic loop laceration grade 5, left adrenal hematoma, bilateral enlarged kidney with impaired secretory and excretory functions, mainly on the left side, mostly due to pre-renal insult. Marked free pelvic abdominal fluid collection, bilateral mild pleural effusion. 3 weeks after exploration, re-exploration was done due to continuous hemoglobin drop. Multiple hematomas were removed. Peritoneal toileting was done. Reinsertion of the drains, subhepatic and pelvic. On day 2 post-operative, bile started to appear in the subhepatic drain. On day 10 post-operative, pelvic drain was removed. Pelvic abdominal CT was done, showing extensive right hepatic loop laceration. Intrahepatic biliary radical injury is suspected for better assessment with HIDA scan or MRCP. Mild free pelvic abdominal fluid collection. MRCP and ERCP couldn't be performed due to unavailability. Subhepatic drain was accidentally slipped 14 days post-operative, leaving controlled biliary fistula. Conservative management with close follow-up was done clinically by laboratory investigations, radiological by ultrasound. Bile leak was decreasing by time. Complete cessation of bile after 2 weeks. Other specialties consultations. Nephrology consultation regarding oliguria on admission. At first, IV fluids to correct dehydration. Then hemodialysis started 10 days after first exploration and continued for 3 weeks. Neurological consultation, CT brain was done showing right frontal cortical based hemorrhagic contusion and subdural collection. Neurosurgery consultation, conservative management in the form of dehydrating measures under cover of tight nephrological follow-up. And finally, physiotherapy and nutritive therapy. Damage control study, goal, treat severely injured patients. Their condition requires an immediate...
First, Sharif, please. First,
Tamam.
I need the comment of Dr. Abdul Latif and Dr. Mohammed Hisham about this scenario. We want to explain and illustrate what was the things that had been done for these patients since the incident of trauma was okay or not, and we explain this. The slide about the damage control surgery, we have to discuss in this slide. So would you mind, Dr. Abdul Latif and Dr. Mohammed Hisham, to contribute to this?
Sure, sir. Good evening, everyone. First of all, the patient was explored outside the hospital. What I know about this case that they have a protocol in this hospital that they do a PAN CT for any polytrauma patient, a non-contrast CT. Upon which they took the decision to explore the patient. Although this wasn't our protocol as pediatric surgeons, we usually are more conservative for such cases and depend more on the vital signs and the general condition of the patient. So it seems that when they found that there is blood leakage inside the abdomen, they took the decision directly to explore the patient. After which they did well by putting intra-abdominal packs, and then they referred the patient to our hospital later on.
So they have the facilities to do CT scan?
Yeah, they have the facilities. They have a CT scan unit inside the emergency department.
Okay, but they didn't make use, or do you think that doing CT scan and dependent on the CT scan findings, the decision to explore patients after blunt trauma is a good decision?
I don't think it's going to be a fair decision, because we have to depend on many things. First of all, we have to know the site of the leakage, and this will depend on contrast injection. This is the first thing. And also we depend mainly, as I said, we are more conservative regarding the pediatric trauma patients. So I think they could have managed it more conservatively if they could done.
May I ask the question in another way? When are we going to do exploration for patients with blunt abdominal trauma? We know that 90% of cases with blunt abdominal trauma in children are managed conservatively or are managed non-operatively. We don't say conservatively, but non-operatively. So could you explain for us, Dr. Mohammed, what are the indications for taking the patient to the OR? This was clear from the report that the patient had, or this was not clear?
Okay, first of all, we depend on the vital condition of the patient. If the patient is hemodynamically unstable, although we are trying to support by giving blood or giving expanders, this is one of the indications to push the patient for the OR. The other thing, if we did contrast CT showing that there is an injury for a major vessel, so I think we have to push for the OR.
Okay. Dr. Mohammed Abdul Latif, do you have something to add for this? I mean, what are indications for operative intervention in a patient with blunt hepatic trauma?
Blunt hepatic trauma, the indication for intervention is hemodynamic instability in spite of extensive resuscitation. The other thing is
can you explain?
If I have a sign of if the patient transfused by more than 40 ml per kg.
Yes.
And there is tachycardia, hypotension, and reduced urine output, signs of hypoperfusion. This will be an indication for intervention. And I think I don't agree with CT because CT is usually done for hemodynamically stable patients.
Yes.
The thing we can do is bedside ultrasound. And the fast will be enough with clinical meticulous clinical evaluation, and in that way our aim will be the damage control surgery. As long as the patient was transferred to us with hemodynamic instability condition. So I think they did a good job in their surgery because they put successful bags and 2 drains. But the other thing, the patient wasn't safely transferred because he was shocked after transfer.
So you think that I would like to add the very important things, that the ideal CT scan in the trauma situation should be a CT scan with IV contrast and oral contrast. Why this? And as well, if we have even an isolated trauma to the abdomen, we have to include the chest as well in our CT scan images. The thing is that because this type of CT scan should be in this way to have, because my indications for exploration of these patients depends on 3 things. First, as you said, hemodynamic instability. Number 2, presence of ruptured diaphragm. Number 3, if there is a suspicious of a hollow viscous injury. So yes, no conservative treatment, or we should go and explore the patients in these situations. The second important thing is that we cannot transfer the patients to the radiology suite except if he is hemodynamically stable. So patients who are unstable hemodynamically should not be transferred to do CT scan. So CT scan will not be priority in this situation. And as you said, resuscitation should take a priority, or should be a priority. You said that our threshold for saying that these patients had a good bolus of IV fluids or blood is 40 ml per kg. What is the definition of massive blood transfusion? Because blood transfusions, even in the trauma patients, now is very critical for the outcome of these patients. So would you mind, Dr. Mohammed Hisham or Mohammed Abdul Latif, to explain for us what we mean by massive blood transfusion protocol?
Massive blood transfusion for children is defined as the need of more than 40 ml per kg in 24 hours. Actually, there is more than one definition because the evidence is low about massive blood transfusion in the pediatric age. One definition is 40 ml in 12 hours. bagged RBCs. Another one is 80 ml in 24 hours, whole blood products. But the most recent publication in Journal of Pediatric Surgery defined massive blood transfusion is a requirement of more than 40 ml of any blood product in 24 hours.
Good. And so if we reach this situation or this point, so what are the types of blood and blood products that we have to give to this patient to avoid complications of massive blood transfusion? I mean, do we have any formula that we are applying or using when resuscitating patients when they reached their maximum amount of transfusion that you described, 40 ml in 12 hours or whatever?
Actually, the massive severe hemorrhage will initiate the vicious bloody circle, which is acidosis, hypothermia, and coagulopathy. So our aim in massive blood transfusion is to transfuse a big amounts of blood in a short period and to minimize the complications of transfusion, mainly the coagulopathy. The accepted ratio now is between bagged RBCs and fresh frozen plasma is to be 1:1. One
and platelet as well, one. One.
Actually, in the literature, 1:1 is approved in the adult age, but in the pediatrics, there is many ratios: 1:1 bagged RBCs to fresh frozen plasma, 2:1 bagged RBCs to fresh frozen plasma. But the most recent studies showed that the complication ratio will be less with 1:1 ratio. Platelets are given accordingly. It's not 1:1 like the adults.
Yes, okay, but not to confuse the situations. Actually, you have to give blood products in equal amounts to avoid the sequelae of giving whole blood or IV fluids that will lead to the initiation and maintenance of the cycle of the coagulopathy that will lead to a bad outcomes in these patients.
Yes.
Can we expect, Dr. Muhammad, from the start that we will have complications like these biliary fistula in these patients? I mean, since the patients came, we explored the patient twice, and we did not identify the presence of biliary fistula in these patients. Is there any predictors in these patients that can help us to anticipate the presence of these problems, and so we have to proact to avoid them or treat them or not?
Yes, in these patients, actually, we were expecting that. To know about biliary injuries, it's very rare in blunt abdominal trauma, especially the extrahepatic biliary system, which is more common in penetrating trauma. But in blunt abdominal trauma, it's usually intrahepatic biliary fistula, and in that patient specifically, grade 5 injury means that about 50% of the right hepatic loop was disrupted. That's why the occurrence of intrahepatic biliary fistula can be suspected from the start, and it's usually a late fistula, not presenting from the start.
What do you mean it is not present from the start?
I mean, it will not be an on-admission presentation. Usually, it showed up after 1 to 2 weeks.
Yes, we usually not discovering it, but usually it is present since the incident of the trauma. We don't discover it because, for example, in this patient, there was a large hematoma in the right hepatic loop, and this did not allow us, or this did not reveal the fistula early. And this is what is commonly occurring in the literature. That's the associated hepatic traumatic biliary fistula with hepatic trauma is usually diagnosed late. But if you look at the CT scan of this child, you may anticipate, I don't mean this one, but in general, in the patients with hepatic trauma, especially if a severe one, like you said, it's a grade 5 injury. So an attriation or a trajectory of the lacerations through the central part of the liver may give us a clue, or may give us a predictor or an indication that these patients may have the may develop biliary fistula because of the site of the lesions in the central part of the livers. Such patients that we are facing with a severe injury to the liver, with a big liver hematoma and liver lacerations as well, can give us an indicator or an indication that these patients may develop a biliary fistula. Okay, if we have a biliary fistula, so what are the plan of management, Dr. Mohammed Hisham? What's the plan of management of this traumatic biliary fistula that we discover in this patient or in these types of patients?
Usually in these types, if the fistula is controlled, meaning that we are not suspecting an intraperitoneal leakage and there are no manifestations of peritonitis, then we will wait for the biliary fistula to regress, because most of them will vanish eventually by the time.
But we have to make sure that this fistula is drained outside.
Yeah,
what I mean that you have to drain the collection that is present. If it is contained and it is not revealed in the peritoneum, well and good, but this should be drained outside. Otherwise, these patients will develop eventually symptoms of peritonitis, biliary peritonitis, or secondary infection by bacteria, and the patients will develop septic complications. So the biliary collections or bioloma should be drained outside. And this is, I think, what you mean by controlled fistula.
Yeah, exactly.
What are the factors that's why we think that all biliary fistula will close spontaneously, and we should work conservatively on them? How can we be sure of that?
Excuse me, how can we be sure of what?
If we have a biliary fistula, we have to do some workup. So we can be sure that this patient, yes, the conservative treatment is most likely to succeed. Otherwise, we may say that these patients may not have a successful conservative treatment, because not all biliary fistula will close spontaneously.
Yeah, exactly. As you said, that we have to be sure that there is no intraperitoneal leakage, and we have to make the radiological studies which can ensure that the biliary leakage is not coming from a main tract, and that is contained to come outside.
Okay. Dr. Mohammed Abdul Latif, can I ask the question in another way? What are the indication of early surgical intervention in a case with traumatic biliary fistula?
Actually, this will depend on the type of fistula. We have two main types: extrahepatic, as I said before, extrahepatic biliary injuries, and intrahepatic. And the intrahepatic biliary injuries is further subdivided into central, like you said, and peripheral. The most likely one to close spontaneously is the peripheral one, as the case we are presenting now. The extrahepatic one is most likely to be operated upon, especially if the common hepatic, if it was affecting the common hepatic or the common bile duct. At that time, we can depend on the T-tube closure or the Roux-en-Y loop. Also, the left hepatic duct is one of the most common sites that will need reconstruction. The central hepatic fistulas, by definition, the central hepatic portion is 5 centimeters away from the porta hepatis in all directions within the liver. Those types of injuries we can conserve upon, but with high suspicion because at any time we can convert to a surgery. The peripheral types, intrahepatic lesions, eventually will close up in about 2 to 3 weeks.
But I have here to highlight some things, that the left hepatic duct injuries is an intrahepatic type of injury. And it will retract and it will close and it will not leak. But the patients will develop liver cirrhosis later on. So dealing with these types of injuries surgically is very important. What I mean is that, yes, although we say that most of the cases of the traumatic biliary fistula can be treated conservatively, but we have to determine and delineate the anatomy and the type of these fistula. So we have to do investigations to know this. We have the MRCP or ERCP. What do you prefer, MRCP or ERCP?
This will
in
be
addition as well, HIDA scan is of value as well to see if there is leakage or not. So HIDA scan is a possibility. Doing intraoperative doing cholangiogram through the gallbladder as well is a way for visualization of the biliary system, intrahepatic and extrahepatics. But the less invasive MRCP is there, and the ERCP is there. If you have the two, what do you prefer?
This will be according to the clinical situation. In that patient specifically, I will prefer MRCP because it's a peripheral type of fistula. It's a low output. It was a low output fistula, not a high output one. So MRCP will be a non-invasive technique, more rapid. And I am suspect there is no therapeutic value from MRCP, but according to the clinical situation, I need just to diagnose.
If you ask me, I'll tell you I will do both. If I have both, I will do both. MRCP is, as you said, non-invasive. It can assure me that I have what type of biliary leak. And as you said, it can give me a clue that a conservative treatment most probably will be of value. But if I want to have a modality that can help me to diagnose more sensitively the lesions, as well as give me a chance to intervene therapeutically, so I am going to choose ERCP. Although, as you said, it needs more stable patients, it's more invasive, and as well, it needs an expertise that should be available to do it, especially in young children. Okay. Do you have something else to say about this patient? Of course, as you had seen, all of us had seen that these patients stayed for about 75 days or something in the hospital, and we had an example of how multidisciplinary approach for these patients is useful. We have neurosurgery, we have nephrologists who dealt with an acute renal failure in this patient, as well as physiotherapy and nutritionists, and of course our surgeons all had done a very good job. Thank you very much. Anything you want to add, Dr. Hisham or Dr. Abdul Latif?
Thank you, Dr. Osam.
Thank you, Dr. Osam.